Hello, everyone who's joining us. We still have a few more people who are hopefully going to join us, so we're going to give everyone some time. Hopefully, we'll begin shortly in about a few minutes, a minute or two.
You can connect it to the.
No, it's fine. I have battery.
Let's go ahead and start, I think. Yeah.
I think I should start. Yeah.
Yeah.
Okay.
Let's do it.
Okay, sounds good. Hello, everyone. Thank you for joining us. We have a few more folks who hopefully will be beginning and joining us soon. But thank you for taking the time out to join us. Our hope is that we want to talk about acute ischemic stroke, non-hemorrhagic stroke. And what we hope to do is foster a collaboration between Safety Hospital in Mumbai and our organization SBMAA and grow a partnership between the two organizations, improving the care of patients who have ischemic stroke. And the way we want to do that is by presenting what our practices are, how we treat stroke, and how we diagnose stroke. And then we want to hear from you all at Safety Hospital how you also treat, diagnose, and manage stroke. And then form a collaboration to see how we can both improve. So that's why we're all here, and we hope this will benefit everyone involved. If at any point anyone has any questions, please let me know. We want to make this as interactive as possible for everyone involved. So again, we talked about this briefly. We want to present what our standard of care is for the diagnosis and management of acute ischemic stroke, specifically with the emergency triage process, and then with the acute intervention, whether that's thrombolysis or neurointervention with endovascular therapy. We're going to talk about the practices that we are doing, as well as new recent advances that not everyone is adopting, but that we have adopted, which we hope to stay ahead of everyone else. And ultimately, the goal, as I mentioned, is to create a platform. This is a first step between our organizations to help improve and elevate care, especially at Safety Hospital in Mumbai. Just a brief introduction on who's going to be speaking on our end. My name is Dr. Eliezer Saharwala. I'm a vascular and non-interventional neurologist from Dallas. Then we have Dr. Muhammad Manasawala, who is a neuroradiologist from Maryland. And then we have Dr. Amir Badruddin, who is triple boarded. He is a neurologist, a neurointerventionalist, and a neurocritical care intensivist as well, from Chicago, here in the US. At this time, I just wanted to take a check and see who has joined us from Safety Hospital. Dr. Murtaza Bagwala, are you there?
I did see Dr. Bagwala briefly and then he
Okay.
got disconnected, but
Oh,
I
okay.
think if Dr. Mehta, if you want, do you all briefly want to just introduce yourselves to and us? I'm sure you know each other, but we could do that.
Probably, yes. I'm Dr. Rajiv Mehta, and I'm the head of the Department of Imaging at Saifi Hospital. I'm connected with the hospital since its inception, that is from year 2004. And recently we have acquired the new MRI machine, that's a Somaton 3 Tesla Vida machine, which is considered to be one of the latest in the MR technology with dip resolve and everything, so we can get the much faster sequences. And we have the very active stroke department. We almost see in a week at least 6 to 7 minimum acute stroke, maybe more but not less, acute stroke patients. And we have streamlined certain things that by which the patients come from EMS straight to the Department of Imaging, and from there it can either be decided on the interventional thrombolysis, or then it can be shifted to the cath lab for the further vascular intervention. So I think once you present it, then maybe we can tell you what we normally do as far as the sequences are concerned and what is our current practices, and maybe what we can learn something from you guys.
Excellent. Thank you, Dr. Mehta. I see some other names from Safety. Do you want to introduce yourself, your name, and your role?
Hello.
Dr. Zafar, there's a lot of echo. There's a lot of echo, Dr. Zafar.
Maybe Dr. Mehta can just introduce everybody else.
Yes. If you do you know? Yes.
I think Murtaza Bagwala is, I think, probably logged in now. Murtaza,
yes, sorry, some technical issues.
Yes.
If you want to just quickly introduce your colleagues, then we can, and what their roles are, then we'll move forward.
So we have Dr. Rajiv Mehta. He is the chairman of radio diagnosis in Safety Hospital. Then we have Dr. Dipesh Agarwal. He is the head of ICU in Safety Hospital. Then we have Dr. Syed Mohd Zafar, who is a consultant neurologist in Safety Hospital as of now. And myself, Dr. Murtaza Bagwala, I am the head of emergency in Safety Hospital. So as of now, we have 4 colleagues join in. And I'm pretty sure we have a few more to join in some time.
Okay. All right, thank you, thank you. So why don't we go ahead and we can get started? We want to present our information, but then we want to hear from you all, so we can move forward. So, when we are all physicians, we like talking about, cases. So I wanted to present a quick case. This is a 75-year-old man who presents for 6 hours of right-sided weakness and aphasia. His family called 911 here in the US, which is an emergency line, and then the ambulance brought him to the local ER department at a hospital that does not have in-house neurointervention. So, from just the presentation, we know this is likely going to be a stroke. And as a physician, we know, what needs to happen. But just with this typical case, right, what I want to highlight are a few things. One is, whenever we have a patient, we talk about the age, but we also talk about functional status. We talk about the time window for intervention based on this history. We also mentioned cortical symptoms, which will come up later on. And then the method of presentation is also important. And then finally, appropriate triage. So just based on just this bare amount of information, there's so much information and so many options for further intervention, and that helps us decide how the patient should be treated, where the patient should be treated, if the patient should be treated based on this. And so this leads into my next slide, where we have additional information. The patient is hypertensive. He is confused and nonverbal, cannot follow commands, right-sided weakness. And the patient, the wife is at bedside, and she tells us that the patient has several risk factors for acute ischemic stroke: hypertension, hyperlipidemia, coronary artery disease. He is a current tobacco user, and he's on aspirin at home. So, as a physician, we always think, what's our next step? We think this patient is having a stroke, he has a risk factor, he's hypertensive, he's on aspirin. And so, automatically we think, okay, the patient should be in the ER, he should get neuroimaging, and then, we have to go and make sure he doesn't have a stroke, and if he does, to treat him. But I want to change that thinking process a little bit. Our thinking, our thought process should not be what is our next step, but rather what is our goal? What are we trying to achieve with this patient? And so by changing that is a very small change in our thought process, but it helps us address outcomes. It helps us figure out what are we actually trying to achieve. And in this case, what we're trying to achieve is the question that is this patient eligible for IV thrombolysis or thrombectomy, mechanical thrombectomy. And by making that small shift in our thinking, it helps, everything else follows through, whether it's the presentation, the initial triage, the initial management, even the post-acute care management. And so I want to make sure that I bring this topic up initially so we understand that by understanding our goals, we can help make changes in our processes. So, everyone here on this call understands that, acute ischemic stroke is an emergency. And what I really want to emphasize is that time is extremely important in all these cases. The goal is to prevent the core tissue, the goal is to prevent the penumbra of the brain from becoming a core infarct. And as you can see, initially the penumbra is a large area, but over time, without intervention, that penumbra becomes infarcted tissue. And so we want to prevent that. And so we have our systems of care in place to do that. We start with the pre-emergency screening. So a patient is called in by EMS. This is before the patient even shows up to the hospital, before showing up to the ER. Here in the US, we have many, many screening tools that we use. We have something that, is very commonly known as BFAST, which is an acronym standing for these symptoms of balance, vision, face, arms and leg weakness, speaking difficulties, and then time. There's a lot of other scales out there. The Now, I'm not going to go through each and every scale because we can all look them up, and it's, they're all different in small ways. But there are some issues that I want to highlight specifically with this process. One is that, our scales should be used in such a way that we can help triage patients. If you remember, we talked about this patient. He had aphasia. And so when we think about aphasia, we think about a patient that has clerical signs, possibly a large vessel occlusion. So should this patient, for example, be directed to a center directly with access to neurointerventional capabilities? Here in the US, there's a system of care. You have one. Sorry, can someone? Thank you. So here in the US, we have systems of care on a regional level. There are, so for example, a giant city area or a giant region that develops a model where all the EMS companies, all the hospitals are all in agreement. All right, thank you. So as I was mentioning, we have a systems of care, and that's, helps us on a higher level to help triage these patients. Secondly, bystander awareness. The public needs to be educated to identify that the patient is having a stroke even before coming to the ER. And so that's extremely important. Here in the US, there are campaigns for stroke awareness. There's a whole month for stroke awareness. It's being taught in primary schooling as well at different organizations that, folks need to be aware that, stroke is an emergency and they need to be taken to the ER. And then finally, from an anatomical and a medical perspective, most screening tools that we use target specifically anterior circulation symptoms. So, aphasia, motor weakness. They don't really talk about posterior circulation symptoms. And so there are other screening tools out there, and they're more being developed. But that's something to also talk about and discuss with your EMS team, with your regional group, that we should not be missing some of these patients, and there should be a higher level of awareness by our EMS staff as well, that we're not missing some of these patients. So then we talk also about time windows. When the patient presents to the ER, the old standard that we were using is, if a patient presents within 4.5 hours of what we call last known well, they're eligible for thrombolysis just based on a time window. And the thrombectomy typically was within 6 to 8 hours. The standards are now changing. We're moving towards neuroimaging and less time window based standards and for inclusion criteria. I won't talk about this here. I'm going to defer this to Dr. Badruddin, who's going to talk about thrombectomy specifically. But the end result of all of these trials that have come out is that our stroke window has expanded now to within 24 hours. So if a patient presents with acute new onset of stroke symptoms within the last 24 hours, that patient should be treated as an emergency. There should be a code-like system in place for these patients. And that's now being adopted across almost all the emergency departments and hospitals here in the US. Once the patient comes in, everything that you see on the right-hand side, that's what we do. And this all has to be done, everything all at once. And so the way we achieve this here in the US is by raising this as a code level, as if someone was having a cardiac arrest. That's the priority we assign stroke patients. And the way we do that is by trying to create a pre-notification system. So the ER staff, the ER physicians, they are aware that a potential stroke is coming into the ER. So before the patient even shows up to the ER, everyone is in place. The radiologist, the pharmacist, the lab technician, everyone is all in place. So then boom, boom, boom. All these steps that we talk about on the right-hand side, stabilization, imaging, lab work, IV access, and then procuring the thrombolysis agent that's all ready to go even before the patient can come. We can have everything set up. The problem with having this system of care is that, yes, it works well, but is it cost both financially as well as for resources? Because then you need someone to be available waiting for the patient. You need someone to be sitting down and essentially not able to do anything else in the meantime. And so this is always an issue that many hospitals have worked with here in the US. And it works really well when it does. It helps decrease our door to intervention times, which is the main metric by which we use here in the US to gain to show that outcomes haven't been improved. And then one last thing I'll mention here is that let's say a patient is already in the hospital. He can also still have a stroke while being in the hospital.
Daddy, they don't have pediatricians in Dubai or what?
Thank you. So once a patient is in the hospital, right, you can still have a stroke. And these patients typically, based on data and research,
She'll have to
show-
add full uninstall at ages ago.
If you could kindly mute yourself, please. Everybody on the phone call, could you mute yourself, please? Thank you.
Okay, thank you. So as I was mentioning, these patients that have already been admitted to the hospital, they have poorer outcomes and higher mortality, specifically because these patients are oftentimes in acute reactive states. They have an infection, they have some prothrombotic state that puts them at a higher risk of having infection. Oftentimes these patients that come in and they are on anticoagulations and they come in for the procedure and it's being held, higher risk of having stroke. These patients are often sicker, they're bedbound, maybe they went ahead and had a cardiac procedure done, and so the likelihood of having strokes is higher. But at the same time, they're less likely to be diagnosed. The nursing is different on the inpatient wards than in the ER. The mindset is not there that these patients can have strokes. And because of that, they're less likely to receive the same treatment that a patient coming to the ER would have. And so that's why it's very, very important to keep this in mind. And this is a challenge that we've had in many hospitals across the US. I've personally been involved in some of these cases and discussions myself. And the solution, and we can talk about this more, is that we should have the same response, the same system of care for any patient presenting with any new stroke symptom, whether they're in the ER or in the hospital, whether it's 2 p.m. or 2 a.m., whether it's a Monday or whether it's a Sunday. The better the processes are for the system of care, the better the outcomes. So now I'll hand it off to Dr. Manasawala, who will talk about neuroimaging.
So I'll start with basically, if you can advance it one more slide, Alias, and then I'll come back to this one. So our general protocol is this. And so if a stroke code is called, like Dr. Sayarwala was saying, it'll go straight, the patient will come, get all of the initial blood work, IV, all that, and come straight to imaging. A stroke code is on the same priority level as, and like any trauma, like a level, it's considered level 1. And so we have to have a certain turnaround time for that, which is in less than, usually between 15 to 30 minutes, but even that is too much. Usually you want a less than 15-minute turnaround time. Most of the time goes in acquisition and post-processing. Once the images hit the list, we strive to have a 5 to 10-minute turnaround time on strokes. So we'll get an initial unenhanced CT. Back in the, years ago, they would do an initial unenhanced CT, and then they would see if there was hemorrhage or not, and then do a CT angiogram and perfusion based on that. But typically now it's one package where you have the initial unenhanced CT, and then you go straight to CT angiogram and perfusion imaging. So it's a whole stroke package. And we do thin slices, we do maximum intensity projection images in the reconstructions in the 3 panes, and then we do the time acquisition with perfusion, where and then the scanner will, software will generate the volumes, flow, and transit times. If you can go back now one slide, then so the initial unenhanced CT, you know, the clinicians are doing this, obviously. We don't always dictate it. We don't necessarily dictate an aspect score, but we're looking for these areas. The clinicians will determine what they feel the aspect score is, and then based on that, move forward. If there's a huge hemorrhage, then the technologist may call us and say there's a massive hemorrhage, and then we may decide not to do the perfusion. But majority of the time, 99% of the time, we do the entire protocol. If you can advance it. So the perfusion scan will be done. It generates these types of maps. Different softwares have different color scales. I think the one on the bottom is Philips. I'm not sure which one the top is, but essentially they'll have their own color scales, and we'll evaluate volume, flow, and mean transit time. We will, we'll look for areas where volume and flow are matched with elevated mean transit times, and consider those to be areas of infarction. And you can see in that lower case where the area that has very little or no volume, relative cerebral blood volume, corresponds well with the restricted diffusion on the diffusion weighted imaging from MRI, which is your core infarction. And then you see the area that is yellow and green on the Tmax in A, which has preserved relative cerebral blood volumes, and is what we know it to be the penumbra, which is the salvageable tissue, and then consideration can be given to going to thrombectomy, mechanical thrombectomy. Next slide. So then the clinicians will make the decision on if there is a large vessel occlusion, and they have certain parameters on the perfusion imaging, then, and given the size of the core infarction and penumbra, whether it behooves to move forward with mechanical intervention. There are obviously pitfalls when it comes to CT. If the patient's too early to see the infarction, if the infarctions are very small, lacunar type, commonly posterior fossa infarctions are not as well assessed by the perfusion imaging because of the slices that we are doing. So they may be underestimated. If the patient has underlying poor flow for various reasons, then it may just result in inadequate or suboptimal opacification of the arteries or flow. There's obviously a lot of technologist dependency as well. They have to put the ROIs in the appropriate arteries and veins, and you have to look at the curves as well to make sure that the curves are appropriate when you're interpreting the images. So that can be a pitfall or a point of limitation. Seizures can be an instance where there may be hyper or hypoperfusion and can disrupt what the perfusion looks like. There's a concept of luxury perfusion. This is not obviously applicable for a patient coming in with symptoms and signs of stroke, but in a case where you may have an inpatient who's had some kind of recanalization procedure already, then they may have this post-ischemic hyperperfusion that could look like a contralateral hypoperfusion. But ultimately, we try to do this as quickly as possible because we know that the next step is based on how quickly we can get these. And honestly, we're doing this, but at the same time, the interventionalist is also looking at it, right, and sometimes they're at the scanners looking at it. So, but typically they may even see it sometimes before us because they're literally at the scanner looking at it. But the post-processing does take some time, so they may have to wait for that.
Thank you. So before we talk about thrombectomy, which is I think going to be the core portion of this topic, we want to talk about IV thrombolysis. That's also equally as important. And so I'm not going to go through each and every criteria. This is something that, physicians, doctors who are treating acute strokes know this. But I want to mention a few things that are changing. So when we talk about contraindications to IV thrombolysis, right, we typically have two sets of exclusion criteria. We have absolute and we have relative. And I don't know how much you all might be familiar with the American healthcare system, but it's very, very, there's a huge aspect of medical legal liability that's here in the US. And so when any physician is taking into account any of these considerations for thrombolysis, that's always in the back of their minds. That can this be justified medically, but also from a legal liability standpoint, can this be justified? And because of that, that's why these criteria are written as absolute and relative. But in reality, almost every contraindication can be relative. Some of these are very hard and fast, but as we get more information, more data is coming, these guidelines are changing and practices are changing. Typically, we were told that any patient that's on any anticoagulation cannot get any IV thrombolysis. That's now changing. There are some hospitals in the U.S., some systems of care that actually are now giving IV thrombolysis with connected place for patients who are on a 10A inhibitor for whatever symptoms they have. Even if the INR with Coumadin or warfarin is 1.7 or 1.9, we still may give it. So that's changing. Secondly, the time window that we typically talk about with 4.5 hours, that also is changing. Again, from a legal standpoint, it's hard to make that decision making, but among talking to my colleagues and in conferences and trials, that time window is likely going to expand, especially if you have MRI-based acute emergency imaging, which again is very, very challenging given the costs and the logistics behind that. But these guidelines are going to change in the US and are changing every single year. And so we should expect that we are allowing the most number of patients to get IV thrombolysis. I'm not going to talk too much about alteplase to connected place. I think mostly everyone in India is using connected place already. I think the US is actually catching up. We were backwards and we were using alteplase for a long time, and but now we're using connected place for IV thrombolysis. The cost, outcomes, ease of use is all better with connected place. And then the other portion of this with IV thrombolysis. So the barriers. So what barriers do we have for a patient to receive this? One is the time window that we talked about with 4.5 hours, and that's changing. With the most recent trial, the Aramis trial in 2023 that came out, for low NIH strokes, there is equipoise between giving IV thrombolysis and dual antiplatelet therapy with aspirin and clopidogrel. There's data showing that there's equipoise between the two. And so there are some patients that we don't give IV thrombolysis that meet certain criteria. And that's also something that we should think about too. When a patient does receive IV thrombolysis, then that patient is typically here in the US admitted to the neuro ICU if there is a neuro critical care ICU. If there is none available, that also complicates IV thrombolysis. Time window we talked about, and then as we mentioned in the inpatient side, recognition awareness is very poor with this. And then finally, this guideline came out. It's now been 2 years, but there was some practice in some centers where if a patient was eligible for mechanical thrombectomy, they were withholding thrombolysis for a number of reasons. That's not recommended. Dr. Vedudin can talk more about this with thrombectomy, but the guidelines now recommend that any patient who can get thrombolysis, regardless of whether they're eligible for thrombectomy, should get thrombolysis, IV thrombolysis. And if you don't have thrombectomy capabilities and the patient shows up to your ER, you should initiate thrombolysis and then transfer for thrombectomy. And that's current practice and how most hospitals in the US operate. And so now the most exciting portion, I feel like, in our talk. Dr. Badruddin, I'll hand it off to you.
Thank you. Next slide, please. So, my focus is, of course, large vessel strokes, but I think there are far too many small vessel strokes which should not be ignored, right? Because strokes are almost as devastating as large vessels are. But given that, large vessels are the mortality is very high with them. And TPA does not work if the clot is more than 8 millimeters in length. So TPA by itself is not going to do the trick. And I think Dr. Manasawala and Dr. Sarwala spoke about detecting the large vessel strokes, looking for cortical signs, looking at the imaging, and detecting them early on and coming up with a plan as to what needs to be done. Thrombectomy is still not 100% here in the US, but we have come a long way over the last 5 to 7 years. A lot of hospitals either provide it or they have an agreement with another hospital where these patients can be shipped so they can get the thrombectomy done, because not every hospital has a neurointerventional program. They may not have physicians, they may not have the equipment, the biplane suite and things like that. So almost every hospital has some way of dealing with a large vessel occlusion, either in-house or transfer the patient out. The technical efficacy for these procedures is now reaching more than 90%. The data is very clear now, and I'll go over some of this data as to who is eligible for mechanical thrombectomy. Next slide, please. So this is a consequence of an untreated large vessel stroke. This is a 40-year-old male, came in with a right MC occlusion. Unfortunately, he was outside the time window. This is a fairly old slide when we didn't intervene beyond 6 hours. And he had a very large stroke, required a decompressive hemicraniectomy. And this can be very devastating for a young person like him. Next. So this is an example of what mechanical thrombectomy does for a patient when it works out well. You can see on the left side of the screen there's a MCA cutoff right there where Dr. Sarwala is pointing. And then after mechanical thrombectomy, the blood flow has been reestablished. And this gentleman did really well. His NIH stroke scale went from 14 to 0 within 24 hours. Next. Here's an example of some of the clots we have pulled out, and we take a bunch of these pictures every week to kind of celebrate them within our team, and kind of exciting to see when these clots come out. Next. Some of the techniques that we are using here, on the left upper corner is the aspiration catheter that engulfs the clot, essentially a vacuum device. You snake up a large bore catheter, as large a catheter that you technically could possibly get up there, and you engage it with the clot and you aspirate, and the clot hopefully comes out. Doesn't always work, but works pretty well most of the time. The device below is a thrombectomy device, also known as a stent retriever, and there are many different brands out there. But this essentially engages the clot by deploying. You can see the picture on the right bottom side, where the device is deployed within the occluded vessel. And the idea is for this device to incorporate the clot or the thrombus, and then you can pull the device back and it drags the clot with it. Again, doesn't always work, but it works fairly well. And a combination of these techniques can get us success rate of more than 90%. Next. This is another example of, here you can see on the left side, there is an ICA occlusion. The ICA is occluded just beyond the ophthalmic bend, and there's no perfusion, or there's no flow rather, in the supraclinoid ICA, ACA, MCA, and then we have pulled the clot out, and the recanalized vessel is on the right-hand side. Next. We also treat tandem occlusions. So when a patient comes in with a carotid artery occlusion, which is acute, and then may or may not have a clot intracranially, then we will intervene, and where Dr. Sarwal is pointing to the occluded ICA here, the origin of it in the cervical segment, and then we place a stent in there, which shows complete recanalization on the right side, and then we'll, of course, if there is a intracranial thrombus, then we'll chase that as well. There's some controversy as to what you should do, whether you should acutely stent or not, and there's a trial going on, Picasso trial, that we are part of, so hopefully we'll have an answer in a year or two. Next. Okay, so what is the evidence that it works? When this first came out, there was a lot of pushback, not only from non-neurology colleagues, but actually even neurology colleagues are pushing back on this and asking, what is the evidence that the thrombectomy works? And these are the first few trials that were done in Europe and Australia and US and elsewhere, in Canada and elsewhere, which shows a clear difference. So at the bottom, what I want to kind of emphasize here is that these are absolute risk reduction. These are not relative risk reductions. So you can see the MR Clean, which was the very first trial that came out in 2015. There's almost a 24% absolute risk reduction. So there's a very large risk reduction with these patients. All of these studies have, of course, different selection criteria for the patient. I won't go into it. You can read that yourself. But regardless of how we pick the patient, the idea was that these patients were benefiting quite a bit from the thrombectomy. So that has eventually now become the standard of care. If somebody comes in with a large vessel occlusion, you should definitely consider them for mechanical thrombectomy. Initially, the idea was up to 6 hours, then it went beyond 6 hours to 12 hours. And then we were getting patients beyond 12 hours. And we were saying, okay, if somebody went to bed at night and woke up in the morning, it's a wake-up stroke. What do we do then? Can we offer thrombectomy to these patients beyond 12 hours? So here is a list of studies that showed, yes, we can do beyond 12 hours. It worked, depending on selection criteria. And even up to 24 hours, there's a DAWN, which is for anterior circulation, and Bausch, which is for the posterior circulation. So even up to 24 hours, we could offer thrombectomy to our patients, and that's has made a significant difference in the outcomes in these patients. Next. So we extended the time window, and we put in place some selection criteria, and we were usually selecting patients with a favorable profile, meaning they have a large mismatch on perfusion scan or a very high aspect score, which means that the most of the brain is not infarcted yet. So then the question was, what can we do to patients who already have a large core? Will these patients benefit from the thrombectomy? So there were multiple studies done, SELECT2, Tesla, which we were part of, and we were looking at aspect score only, especially in Tesla, we're looking at aspect score only, and even up to aspect score as low as 2, these patients were taken for mechanical thrombectomy, and a positive correlation was noted that these patients who received mechanical thrombectomy will do well despite having a large core. So we have come a long way from 2015, when people didn't believe in any mechanical thrombectomy, and now we are doing mechanical thrombectomy on almost everyone. Not everyone, of course, but almost everyone up to 24 hours. Just one small point I want to make here is that at our center, we are quite aggressive about mechanical thrombectomies, so much so that we have actually reduced the use of perfusion scans because it doesn't help us as much in picking the patient, because we're going to take the patient regardless of what the perfusion shows, as long as within 24 hours. So we are not using the perfusion scan as much, but a lot of places do use it, and it's completely okay to do it. I think it's probably safer to do it with the perfusion scan. Next.
Thank you, Dr. Badruddin. So, we want to, wrap up at least this portion. Right. We talked a lot about the hyperacute management, but there's a lot of things that we have not touched on. Stroke, as everyone knows, is a very, very wide and encompassing topic. There is a lot more that happens to these patients after the OR, after the angio suite, after the ER. Once they're in the inpatient, the wards, how do we manage these patients? How do we manage the antithrombotic medications, the risk factors? If they're in the neuro ICU, the neurocritical care ICU, what is the management? And finally, recovery after the hospital stay. And, each of these topics, that we are talking about could be a 3-hour discussion on its own. I'm not going to mention each and every one of these, but the fact remains that there's lots of areas for improvement, areas for education, and areas in which guidelines are changing. I want to highlight 2 or 3 of these. So, and specifically in the South Asian population, we know there's a high resistance of clopidogrel use. That's something that we've seen in my practice. I've seen in my practice as well. That's something that we should be aware of as we treat these patients. In the neuro ICU, management of ICP issues and neurosurgical interventions, and even having a neuro ICU specifically dedicated does improve outcome with these patients that have strokes. As we mentioned, in terms of diagnosing, most stroke patients are, have typical risk factors, but there's a lot of patients who present with unusual symptoms, unusual causes, and even the diagnosis has a lot to be, there's a lot to gain in different diagnostic measurements and tools that we have. And then finally, this is also something that here in the US is gaining lots of traction. But after the hospital, the patient has been diagnosed, has been treated, but they still have significant disability and deficits. How do we make that patient and bring them back into a functional status and back into society? And so there's a lot of different topics that we can talk about. Caregiver burden, especially, and cost is a huge issue as well. And is there a specific neuro rehab model that we can implement, as we do here in the US? Is that beneficial for these patients? So these are all topics that obviously we don't have time to talk about now, but it helps in bridging us to our next steps. So, we presented our portion of these steps, the initial hyperacute phase. We hope that, after presenting our information, we want to hear from you at Safety Hospital, and we want to work with you all to create a work group, whether it's a WhatsApp group or whatever have you, email, and we want to know what gaps and challenges you all might have, and then working with different professionals in different specialties collaborate so we can improve these outcomes in these patients. So again, thank you everyone for at least listening to us. We want to hear from you now. Everyone at Safety, please tell us what your thoughts are, your comments, your questions. We want to hear from you, and we will try to get through all of them in the time that we have remaining. Thank you.
Thank you so much for the amazing presentation. Just a question for Dr. Badruddin that regarding the thrombectomy cases, normally, what are the normal complications which we normally see is the post-thrombectomy bleed. So are there any specific plans in which we can work, in which we can reduce this post-procedure complication?
Yeah, so the primary thing we do is we keep the blood pressure low. If the blood vessel has been recanalized, we keep the blood pressure low, less than 140, and that reduces the risks quite a bit. And there, of course, there's risk of hemorrhagic conversion of the stroke, which usually we don't really worry about it too much, because if it's a dead brain tissue, whether it's ischemic or a hemorrhagic, it doesn't matter, unless it's creating mass effect. Then it's a different story. So we don't really see very high complication rates with our patients. On the order of 5 to 6% is what our complication rate is for these patients. And then, of course, there's some access problems and a few other things that can happen. But in general, it's a fairly safe procedure.
Thank you so much. And I just wanted to ask one more thing regarding that. How well do you utilize your MRI scans for diagnosing stroke? Because we see a lot with CT angiography and CT perfusion scans. So how well do you use your MRI scans as well?
We won't use MRI on an acute in the acute setting, acute phase. Of course, we perform MRI on all patients after the fact to understand, we as neurologists think that we know where the lesion is, but I have been doing this for 20 years and I've always been surprised of how many times I've been wrong, where I thought the lesion was and it turns out to be somewhere else. So I don't rely on just CT for a final determination of stroke. I like to get an MRI.
Typically, the acute is all, we only do because of the time factor, and the fact is the biggest thing that we want to identify, that large vessel occlusion for the interventionalist. So we always do the CTA as our acute. But then once a patient is an inpatient or maybe in the hospital and they might have some symptoms that might be looking for a stroke, then often inpatient exams may be MRIs, to further see, like, once the intervention happened, is there a stroke, or even sometimes before the typically not before the intervention, and if there's a large vessel occlusion, they'll go straight to the cath lab. But subsequently, like Dr. Badruddin was saying, we may do they'd often do MRIs to see what the extent of the actual infarction may be, if any.
I have a question for Dr. Manaswalam. You just showed us the CT-based protocol. So whenever you suspect the posterior circulation stroke, do you think that you go for an MR than a CT?
No, so even regardless of if it's a stroke code, we will always do the CTA and the perfusion first. We will always do the unenhanced CT, CTA, CTP. It's always first line. Always.
Does it mean that after CTP, would you take the patient on the MR table?
So if there's a basilar occlusion or something, then they go straight to the table. They'll go straight to the IR suite. There's no need for an MRI at that point. So we're always looking for a large vessel occlusion, and like Dr. Badruddin was saying, sometimes they don't even do the perfusion, and because for the posterior fossa, it may not even be helpful. So. In the acute setting, stroke code, always CTA, CTP with a dry CT.
I see.
The other issue with MRI is from a practical standpoint. Many centers, when they have an MRI machine, they're not always 24/7. They don't have a technician always at some of these smaller hospitals. Even at larger hospitals, they may not have 24/7 technician coverage, especially in smaller areas. The other issue is cost, right? Everything here in the US is all about cost reduction, and doing urgent stat MRIs means that other MRIs can't get done because then they prioritize those patients. The other thing is with MRIs here in the US, for patients, for example, during COVID, when we had COVID, every MR suite had to be completely scrubbed down, right, which added so much time to the process, and that reduced time to get MRI. And so there's only a few centers that I know of in the US that use emergency room MRI techniques. UC San Diego, I know, does that. At my institution, what we have developed is actually something called an MRI brain attack MRI, in which we have very limited sequences. We just do DWI, T2 flare, ADC mapping, and I think that's it. And that's all we do. It takes 10 minutes to just get those sequences. And we use it primarily for two purposes. We use that for determining if the patient needs to be urgently on anticoagulation to see the extent of the stroke. And then we use it for patients who are unable to tolerate a full MRI, whether it's hemodynamics, whether it's agitation, whatever have you. That's what we've done to get around that. And that's the only real use of emergency MRI that is used here in the US, just from a practical standpoint.
But in our setup at Saifi Hospital, we can do the MRI in less than 10 minutes in acute stroke, especially involving the DWI, SWI, flare sequences, and circle of Willis. If that much we can finish in 7 to 8 minutes. And if we are allowed to use the contrast in most of our patients, then I think we can still in next 2 to 4 minutes, we can do the contrast angio. So we can get the perfect idea about the occlusion plus the diffusion, and some of the case of wake-up stroke, we can get the flare and DWI mismatch immediately will tell us to go ahead with the decision of the thrombolysis.
Dr. Mehta, what do you do in how much screening do you do for the patient in terms of MR safety, in terms of implants and cardiac devices, etc.? How do you do the screening for that so quickly?
I think we normally go by the history. Normally go by the history, and even the ER team also normally screen the patient for all this kind of metallic prosthesis and everything. If they're doubtful about the valve or something, aneurysmal clip or something, then probably we may drop the idea of taking the patient on MR and we switch the patient to CT. But that not too many times we have come across such patients. Unless the patient is unaccompanied by the relatives, patient aphasic, there is no history available. In such case, it becomes too difficult to take them on table.
I'm the MR safety officer in our group in our hospital, and we've noticed a very high uptake of devices, implants, different piercings or other metallic foreign bodies, different other procedures that are now using like endoscopy pills that have to leave the system because they can burn through the gut wall. And those have to you have to screen them. So, you have to, they may have had the procedure 2 weeks ago or a month ago, but they still may have not left the elementary track. So there's a lot of safety things that are growing, and it's just something to be aware of as you proceed with emergency MRIs, that you are, just behooves you to, take all these things, new things into account, and make sure that you're screening patients to the extent that, you can avoid some of these things. Even like some skin patches have silver nitrate on them, and they can cause major burns in the skin. There's a litany of an MR safety is becoming heightened in institutions, especially with burns. And so just something to be aware of as you're doing, when you're quickly taking patients to the, because of the time issue, to cross your T's and dot all your I's before you're doing that.
Could I ask Dr. Bagwala to just walk us through a typical stroke alert at your hospital, at Safety Hospital? How do you deal with a, like Dr. Sarwala mentioned, 75-year-old gentleman coming in with right-sided hemiplegia, aphasia? What happens at your ER?
So as soon as the patient walks in, we just take a quick history. We determine what the patient has, the symptoms, and after that we check the blood glucose level. If the blood glucose is low and the symptoms are suggestive of being of a stroke, with of course the blood pressure and other things to be monitored, and if the symptoms suggest that it's a stroke, so we have a hotline number. So we dial that number 555, and once we activate a stroke code, once the stroke code is activated, the operator, by the time the doctors are doing their work of initial management, the operator will call around in the hospital. They will inform the radiology department. They will inform the anesthetist, ICU team. They all have been intimated. They already informed that there's a stroke patient waiting in the ER. Max, we take our time till when we take the initial history, the time of onset, the past history, the NHS scoring. We try to, and of course, taking down the blood IV excess, doing the ECG. This whole process takes, we try to restrict ourselves in the first 15 to 20 minutes max. In the first 15 minutes, as soon as this primary treatment is done, we shift the patient to the MR. Of course, with the initial screening of patient not having any implants or any valves. And if at all, if they have implants, we have to make sure that they are MRI compatible. The MRI department makes themselves available, or their ongoing scan has been stopped if there's a stroke emergency in the ER. So they stop their ongoing scan, they take the patient out of the table, they keep the MRI table vacant for us. we quickly rush the patient to the MR. We have an initial second screening over there where the patient has been first, second history has been taken down by the radio resident as well, so that we are not missing on any crucial of the data where the patient can have any complications in MR. We have been lucky enough, as Dr. Manaswala just rightly mentioned about all the causes which can cause complication, but we have been lucky enough that we see roughly around 15 to 20 patients of stroke a month, to be precise, and we have not been come across any complication as such due to MR. Once we take the patient to the table, as Dr. Rajiv told that we have the sequences running in um, with the stroke protocol which we have. The sequence are run. We get a quick DWI, SWI, and we get a flare. We determine if there is a restriction on DWI, and then of course we have a diffusion flare. If it's a mismatch, then we determine that it's an hyperacute stroke. So and um with the circle of Willis, we get to know that what are the impact of the stroke. If we see it's a large vessel occlusion, then of course the plan goes for mechanical thrombectomy. If not, then we plan for IV thrombolysis for the patient to cut down the time as soon as the diffusion and the flare is out. And if we are planning for thrombolysis, we go ahead with angiography of the neck vessels as well on the table. And in the meantime, we prepare for IV thrombolysis in the MR console or in the MR recovery room. So as soon as the patient is out of the MR, we take the patient. We don't shift the patient down to the ER, nor we shift the patient to the ICU. We take to the recovery room. We do our inclusion exclusion criteria. We take the consents. We talk about the what benefits and complications can be because of thrombolysis if the patient has to be thrombolized, and accordingly we check the blood pressure, monitor it, get it down below 180 if it's on the higher side, and then we start the initial thrombolysis in the MRI recovery room as well. So with that, it really saves time. And of course, if we determine that there is a large vessel occlusion, then we push it to the intervention radiologist. We get them on board. We activate the cath lab so that the cath lab is available for us. And of course, if time we know that if there is a delay in the procedure and it's going to take more time for the cath lab to get vacant, at that time we look for the bridging where we can bridge the patient till we get the patient to the table of cath lab.
Thank you. Thank you. That was a very comprehensive overview. Could I ask how many IV TPA do you give in a given year, and how many thrombectomies do you guys perform?
If I have to talk about IV TPA, in a month, around 6 to 7 we go for IV TPA. Apart from that, we have around 3 to 4 mechanical thrombectomies a month, and rest of the strokes which are normally out of window. And of course, out of window not being a large vessel occlusion, we don't really push them for mechanical thrombectomy as such. So though the window is extended to 24 hours for thrombectomy, but based on the patient's clinical scenarios and understanding that risk versus benefit complete the ratio, that's when we decide about should we take the patient for thrombectomy or not.
Got it. So what is in the current setup that you have right now? It seems like you're doing very well with everything. What is your pain point? What is not working for you? Where can we help you as a group?
So the one important point, as I asked you, that post-procedure complications, which we have seen in the past. We had Dr. Rashmi Saraf joined with us for the discussion, but unfortunately she had to leave because she's traveling. She's a neurointerventionist, so that would have been great if she would have been on board with us for the discussion. And Dr. Nishan Aditya, of course, even he is there, but he called me up that he is in right now in cath lab doing a DSA. So it just got worked up, is not able to join with us. But of course, the problem what happens is that post-procedure complications of IC bleed, that is something which we are worried about. And touching the brain for a small infarct or a small vessel which is occluded. Of course, we don't take it for the small vessel though, but for a small infarct, then that is where we So the real problem lies with the post procedure complications.
Okay. Okay. I have to unfortunately leave. I have to see my clinic patients. Dr. Sarwala, could you
Yes,
please coordinate with the group and see, if we can create maybe a
yeah,
WhatsApp group or a follow-up meeting with the
absolutely.
rest of the stakeholders, and would love to get this discussion going forward. And if you wouldn't mind, perhaps we can, create this WhatsApp group and discuss. I will be actually in India I'm leaving this Saturday. I'll be in India. So I'll be in Mumbai for a couple of days. If possible, I'll notify the group in advance. If I could come in person and meet you guys all at Safi, that'd be phenomenal. But if you're busy, I can totally understand.
That would be great. You're most welcome.
Thank you.
Yeah, and it sounds like, the country, you guys are doing very well. There's always room for improvement, both in the ER as I mentioned, it's not just the ER, it's the inpatient wards, it's the ICU. It sounds like, having a neuro ICU discussion is a good next step as well, and how to manage these patients outside the ER as well. I think that would be a very good next step, and we have the right folks to help out with that. But
Thank you.
this was very helpful. Before we conclude, does anyone else have any other questions, topics? Because we can spend 2 3 hours talking about this, but I know everyone has things to take care of on their own. Any other questions for us right now before we wrap up?
We have Dr. Dipesh from the ICU if he has anything to offer.
Yes,
Dr.
hi, this is
Dipesh.
Dr. Deepesh Agarwal. So, there was a last point which I heard a question was what are the complications that we see in the ICU? So, if all goes well, everything is fine, then of course it's a all good picture. But sometimes, rarely we encounter certain complications, such as IC bleed. Our IC bleed rates have been significantly low, well below our international benchmarks, because probably we screen our patients very well, and you know, our choice of patients is excellent from the ER, and then the time spent for the MR is very low. What we see more of complications are after neuro intervention. Uh, Maybe that needs to be fine-tuned a bit, or maybe more data points come. We see a lot of bleeds. A lot of bleeds, no, we see significant bleeds. It may be within the benchmark also. We see IC bleeds, we see post-procedure bleeds uh, after neuro intervention. So from thrombolysis point of view, our complication rates are significantly low. But from neuro intervention, we see uh, disproportionate bleeds.
Thank you. That's really helpful to know. It sounds like, we have a couple of things we can work on, and it may be a combination of very different, numerous factors. That's something I think we can definitely work with you guys, to help, optimize. I think that's a very, a high yield point. So,
I have
yes.
I had a question for the neurologists. When you see patients that have a hemorrhage, do you distinguish between petechial type hemorrhages that you may see versus a hematoma in the brain when you make a decision whether or not to do IV therapy, IV thrombolysis, or and other like anticoagulation? Is there a distinction that you make between the petechial hemorrhage on the gradient that you see on the gradient on the MRI versus a large hematoma? This is kind of for any of the neurologists, both sides. Or any.
We have Dr. Ashish Gosar. Dr. Ashish, are you with us? Dr. Ashish, probably we have lost him. But of course, we can come back to you with this
Maybe
question.
neurologist Dr. Mehta can answer this, because most of
Yes.
our help from distinguishing between a hematoma and petechiae directly comes from the neurologist at that point of time.
The question is that once you know it's petechial or a large hematoma, does that change your decision on giving anticoagulation?
In the IC, what we've noticed, correct me if I'm wrong from a neurologist, is if it is petechiae, we are not that worried because you may get very, very small, minute hemorrhagic or a small, you may call a little leak like what you see after a neuro intervention. It's a contrast that leaks out, which looks like a bleed, but is actually not. Something like that. Maybe if it is very small, the risk versus benefit has to be made against what actually happens. Because if it's a very small petechiae, the benefit would actually be to to give us antiplatelet rather than hold on to it. But if it's actually a hematoma, then you have to weigh those benefits. And
Mhm.
of course, the duration also is important. Is it immediately post thrombolysis? Is the bleed expanding? Is the bleed static? Is it just a petechia, or was it something like a sentinel event or a bleed which was picked up very quickly in an imaging but later expanded? So those kinds of things. But most importantly, if it's a small petechia, we usually don't worry about it when we are considering antiplatelets.
That's kind of in line with what I've heard here as well. Is that correct, Dr. Sahiral?
Correct. If it's petechial, we feel much more comfortable initiating antithrombotics, whether it's antiplatelet or anticoagulation. This is a primary hematoma. One last question I had for anyone at safety. Do you know what your average, what we call door to needle time is? The time from when the patient walks into the door to the time where thrombolysis is actually begun. And any approximate idea?
So we follow a benchmark of around 60 minutes for door-to-needle time.
Okay.
And we try to stick around, but sometimes it might be 65 or 70 minutes.
The reason
So
why,
there can be a
yeah,
delay, but
yeah. The
yeah,
reason
but
why
we'll
I
try
bring
to
up
stick to 60 minutes.
Yeah, no, the reason why I bring it up is so that here in the US, the American Stroke Association, for every hospital, the goal is now 45 minutes. And out of those patients, about 25%, they should be within half an hour, 30 minutes, right? And that's the benchmark that we are using. When I'm seeing a patient, I need to get thrombolysis in that patient who's eligible within 30 minutes. Right? That's the goal that here in the US everyone is working towards. I've given
Oh,
thrombolysis.
that's wonderful.
Yeah, so I've given thrombolysis within, 15, 16, 17 minutes. Like that's not common. But the goal is 45 minutes for every patient and for at least 1/3 to 1/4 of the patients within half an hour. Because that within that 1 hour much earlier, within that first half hour especially, the outcomes for NIH are significantly better as well. And so, that's something to consider. There's lots of and small steps that we can optimize to help you all reach that. Because I think 60 minutes is very, very admirable. 60, but after that, it gets longer and longer. And at our institution, any patient that gets thrombolysis after 60 minutes, that triggers a peer review. Actually, we have a whole system in place saying this patient was delayed. Um, and so I don't know if you guys have a committee that looks at each and every thrombolysis case to figure out what delays happened, if any, and how to improve. We have a stroke committee at every hospital. I'm part of my hospital stroke committee, and we look at each of these cases individually and figure out what went well, what did not go well, and how to optimize that time. Um, so that's something that I don't know if Safety Hospital has
Yeah.
something like that. Um,
We also took an international benchmark of 60 minutes as one of our benchmark. But of course, if we're able to achieve it in 45 minutes, nothing like that, because that every second is equivalent to
Correct.
millions of neurons in the brain. So we understand that. So that's a very good thing, and probably that is something what we can learn. That how one of the factors what we discussed probably is that you use CT angiography versus an MR. So probably that might be a time saver for you for an early thrombolysis. That is one of the point which I take home as a message. And rest assured, anything else if there is there, so we could definitely discuss about it how we can reduce our total real time as well. Just two quick questions. I'm so sorry to keep it long, but just one thing is tenecteplase FDA approved now in US because many of the people who come from the drug company they say that it is not yet FDA approved in US. So I just wanted to know that. Is it?
Yeah, no, that's a good question. It's not FDA approved, but enough trials have shown that it has equipoise, right? And so it's equivalent. And so in terms of the outcomes, they're all, equal, if not better. What we do to justify that it's not FDA approved is when we do our documentation or, notes, we document that this is not FDA approved, but it shows equivalency. And I've never had an issue. And at all the sites I've worked at, connected place has never been an issue, even if it's not. And I have a feeling it's just a matter of
That
time.
takes care of your legal issue as such.
Yes,
Any legal implications coming from a bleed, so that suffices the purpose.
yes. So I've never had any issues with, and I've had petechial hemorrhages, I've had hematomas at the connected place too, and I've never had any issues. And I've never heard of any neurologist here having any issues with that.
Wonderful. And the
I
second
have a
question
quick,
is that if the patient has to be sorry, Dr. Dipesh, you can
yeah,
go
sorry,
ahead.
after bag wala.
Okay, so if at all you have to take a patient for a thrombectomy, so are these patients covered by the insurance so they don't really have to worry about the cost factor as such? Because in India, it's a different scenario. Not everybody has an insurance which would cover such a large amount. So probably the expense is high. So what would be a normal average expense if you take a patient for a mechanical thrombectomy and versus how they are able to afford it?
That's a great question. That is a 2 hour long discussion. The American healthcare system it's a very different animal. Um, patients who have insurance, like if is covered. There are certain areas of the U.S. where patients a significant percentage do not have insurance, right? So we have that case as well. But the way the US healthcare system operates is that we treat everyone regardless of whether they have coverage or not coverage, whether they have the finances or not. We treat everyone the same, right? The problem, is that, let's say they don't have the appropriate coverage and then the finances, that's usually days, weeks after the treatment has been done. There is no discussion of finances in the ER, right? And also, one more point is that when we give IV thrombolysis in the US is an emergency procedure. We do not need consent from the patient or family to administer IV thrombolysis. This is actually in the guidelines. There's no need for consent for IV thrombolysis. So if a neurologist and an ER physician feel the patient benefits from IV thrombolysis, we give it regardless. Obviously, the patient can decline, like they can say no if they are, cognizant and they make the right decision. And they can decline. A family can just say no, but we don't require consent. So, again, this is a great conversation to have. I'm happy to asking these questions, but
In a nutshell, that cost is either eaten by the hospital or is passed on indirectly to other patients who are insured. I mean, but like Sairala said, nobody will be, that's not a factor in the treatment algorithm.
I have a couple of quick questions. What is the logistics in the US hospitals from a structure point of view? Like, how are you structured? Where is your MRI? Is it next to the ER or how is it?
Yeah. So, when the patient comes, yes, our MRIs, well, our CTs are right next to the ER or within the ER. And our MRIs are not necessarily in the ER. So, they're all usually on the same floor and they're within a 5 minute, a few minute walk, but the CT scans are usually in the ER or like right there at the door of the ER. Whereas the MRIs maybe will be on the same floor, but are not typically in the ER because the MRIs need additional shielding and different, the whole area needs to be different. So that's at least in the 3 hospitals that I've been at, that was the case.
And the cath lab?
The cath lab is usually, it's variable. It may be on the same floor, but it may be upstairs 1 floor. But Dr. Sarawal, usually that's also on the same floor because again, they want to cut down on every single minute that the patient has to travel somewhere.
So those are one of the few issues that we have. So we have an ER and our MRI is on the other end of the hospital on the 2nd floor. So we have the north end ER, we have the south end MR on the 2nd floor, and then we have the south end cath lab on the 8th floor.
Okay.
So that
Where
is
is
one
your
of the
CT
issues.
machine?
CT MRI is on the south end of the 2nd floor.
Okay, they're together. Okay.
So
Yeah.
it's north end ER, south end 2nd floor MR, and the ER is on the ground floor.
Okay.
So you have to go 2 floors up on the other end of the hospital, and
Okay.
then you have to go 8th floor up for the cath lab. So those are one of the logistic issues. The other thing is, of course, I failed to understand a bit. I actually didn't catch it correctly. If you don't have you don't require a consent, how does the patient say no or the relative say no to thrombolysis?
No, so when the patient is in the ER, we talk about what we're going to do. We say we are recommending IV thrombolysis, right? But if the patient is not able to consent, right? They have significant aphasia, they cannot understand. We don't need consent.
Okay, got it. But if the patient is not aphasic, they can refuse or
They
they can
can,
consent.
they can exactly. They have the option to refuse and the option to say no if they are able to do so.
So basically, it is like
But we do
you
have to.
thrombolyze unless explicitly refused.
Exactly.
This is
So-
Dr.
But we-
Sarawala, is this just for IV or also for mechanical?
This is for IV thrombolysis. I
Right.
think for thrombectomy, because it's a procedure, it's a surgical procedure,
Correct.
I think they need consent.
Correct. I just wanted to make that clear. Yeah.
Okay,
want-
so from the discussion that we've had, our times are slightly longer because of logistics, probably. The other thing is consent and finances, apart from maybe other small things.
Correct. I think you've hit the nail on the head. I think you've identified three major, and again, I'm sure there's lots of small things that come up. But I think those are the 3 issues. I think you've hit the nail on the head very clearly.
Dr. Rajiv would like to say something.
Do you use Rapid AI as a software? For
Rapid
CT and
AI, yes.
MR?
Yes.
Rapid AI?
Well,
you
we're
use it?
using Rapid AI in our CTs. So with our
That's
CT, with our
Tell me
CTs.
one- When you use the MR, actually, generally you do for the contrast perfusion, or sometimes you also perform ASL?
So, Dr. Mehta, like we do almost zero, and this is in my old institution and my new institution, almost zero ASL and almost zero MR perfusion. The only time we do MR perfusion is in the select cases where there's a tumor and they want to know, is there recurrence of this tumor or some GBM or something, and we're doing it for that reason. But in the stroke setting, we have zero use of MR perfusion. We only do CT for the initial. We do have an AI software for that. There's no AI involved in the perfusion, but there is AI involved in large vessel occlusion. So we have a software that identifies LVOs. We have a software that identifies aneurysms, subarachnoid and other subdural hemorrhages. And then we also have for follow-up cases, so cases where there was an LVO, they went to the cath lab, they got reperfused, and now there's suspicion for a bleed within 24, 48 hours. We have this subtraction software that will eliminate the iodine so that you can better, it's called the spectral CT, as you know about. So we do spectral CT on post-procedural, post-thrombectomy cases to see if there's hemorrhage, if they suspect it clinically.
You have a spectral CT in your institute?
Yeah, so we do spectral CT on almost every CT. So we do spectral CT for iodine on heads. We do spectral CTs for
Oncology?
yeah, even for like renal calcifications. We do but it's mostly in my practice personally, the best use is for these post-thrombectomy head CTs looking for bleed, where you can eliminate the iodine. It's very helpful. You know, I have a couple of cases where, you know, it truly helped.
May I ask which system do you use, Philips or Siemens?
Philips.
Philips.
Yeah.
System, yes. I've seen it twice. I've seen the practical demonstration of the spectral CT.
Yeah.
And it's amazing to see the different energies at what.
Yeah, you should work to getting it, because it'll really help you in your stroke, in the stroke workup and post procedural.
But I think for the India it is going to be too expensive a scanner.
Yeah.
As of now, what we are using as of now is also very expensive scanners. So spectral CT is right now out of reach of any of the institution.
Got
You
it.
can never think of break even on such scanners ever.
Got it. Got it.
Okay.
Thank you. Any last questions? I know we've taken a good amount of time. Any last question before we wrap up?
I want to ask you about what about the sedation? Because some of the patients in acute stroke patients are also very irritable and the uncooperative. How do you manage to sedate them? Do you ever sedate them? We normally avoid sedating such patients.
We do. That's a great question. You know, if needed, you know, we sometimes will give a little bit of sedation, just enough to calm them down. But you're right, most of the time we don't. And that's why we use CAT scanning, right? We never use MRI, right? That's one of the benefits of having CT scanning, is that you're in and out in seconds. So you can get a very, very clear, you know, imaging. You don't have to worry about distortion whatsoever. So it's an issue, but it's not as common because we use CT.
One suggestion, Dr. Mehta, Dr. Bagwala, Dr. Agarwal, is that maybe on some cases, start to see if CT perfusion can work for you, you know, in select cases, and see where you might save the 10 minutes or 12 minutes, you know, potentially, and maybe that could be like a slow transition, see how it can work in your setting, consider it at least. And because I think that might help in your turnaround time and some of the sedation issues and all these things too, as well.
And I also understand that in acute stroke setting, you don't worry about the serum creatinine.
Correct.
Yeah, no, not at all. Not at all.
Correct. Correct.
Yeah, not at all.
Around about 2 or 3 level, very high serum creatinine. Doesn't matter.
Doesn't matter, because if the kidneys don't work, but if the brain's not, you know.
Yeah.
We don't worry.
Even if the patient's on dialysis, we don't care.
Yeah.
I think maybe, you know, because our neurologists are more, they like more MR than CT, number one. And they are normally do not like too much of contrast. Because I feel that in acute stroke setting, if I use contrast for MR angio, also my acquisition will be very fast as compared to non-contrast time of flight. But there's a circle village for the time of flight for the brain or for the neck angio. When a besto machine, it will take 7-8 minutes.
Yeah,
but in this case, with the contrast MR angio, I think it's less than a minute and a half. I can do that.
Yeah, you save a lot of time. Your 65-minute time will come down to 50 minutes just with doing CT instead of MRI. Because even if you just do minimum of flare, if you're doing flare, CT angio, CTA of the circle of Willis plus diffusion, that's probably 10 to 12 minutes. And that's easily 1 to 2 minutes on a CTA. Just the post-processing might take a little bit for the but you'll,
Also, I can tell you that we can cut down on the, cut down on the brain timing because we have now the Somatum Veda 3T system with a deep resolve. That will be much faster. We get the much acquisition is much faster when using AI technology.
Okay,
So we have so cute, very fast stroke protocol. So where you can get the very decent and very good high resolution images in less than 7 minutes.
okay.
What I mentioned is BWI, ADC, SWI, and the circle of Willis.
What about the
And
neck?
if there is no occlusion, major vessel occlusion, then probably we can avoid the neck angio at that particular time.
So the difference will, just to contrast the difference, the neck, almost the neck and the brain are like in one, whenever you say brain, you have to say neck with it. Like that's our philosophy here, that the neck and the brain are just one thing. And when you're looking for something, you have to look from the arch all the way up. So that's, I think, the philosophy here that
Yeah,
we,
Dr. Badudin presented that case about the tandem occlusion, right? And that's exactly right. When we think about LVOs, that includes the ICA, and you need the neck imaging for that. So our practice is always, as Dr. Manasavala mentioned.
Yes, I think option, but to go.
Till the till the neck angio goes on, there's a time window which we get to counsel the patient because we do have to take consents for thrombolysis. So in that 7 to 8 minutes, we counsel the patient, we prepare for thrombolysis, we get the drug available in the MRI recovery. And to save that extra minute, probably we do the thrombolysis in the MRI recovery rather than taking the patient back to the ER. As Dr. Dipesh told that we are in two different ends. So to save that time, rather than transporting the patient, we do it in the recovery itself.
So one point I'll make here is that we give thrombolysis when the patient is still in the CAT scanner. As soon as we have the non-contrast head CT, that's all we need, right? No, in addition to history. So as soon as that first CAT scan is done, the neurologist, whoever is there, is down there with them. They see that the head CAT scan looks good. You start giving, thrombolysis right then and there. And then as that's going, you can still get, as vessel imaging. So that's how we optimize our times. We don't wait for vessel imaging. And the guidelines specifically state that there is zero need to wait for vessel imaging before IV thrombolysis.
All
But
right.
what about thrombolysing a patient who has a stroke mimic or a TOT spicy for that sake? And they don't
Yeah.
really. So in the first non-NCT will show that there is no, of course, there's no bleed. And if we thrombolize such patients, so what's the take on that?
So for, we have mimics, right? Every neurologist here is given thrombolysis for mimics. The philosophy and our training here is that the question shouldn't be, should we give thrombolysis? The question should be, give me a reason not to give thrombolysis, right? If it's a mimic, unless you can prove that's a mimic then and there, right? The default is we should be giving thrombolysis, right? That's how our thought process is. We should be giving thrombolysis, right? If you're concerned, you have to have such a high degree of certainty that the patient is having a mimic that you feel comfortable withholding it. And the reason I'll mention that is that, again, it goes back to our medical legal system here, right? All the lawsuits that neurologists have faced in the US have almost always been not that the patient got thrombolysis and had complications. It's the opposite. Why did the patient not get thrombolysis? And that's why all the lawsuits and challenges have happened. So it's a completely different, paradigm shift in how you think, right? If a patient has a migraine and a headache and is a mimic, they get thrombolysis, their bleeding rate is like 0.5%, right? Overall, across the board, it's about 3 to 4%, complication of bleeding. That goes down even more with a mimic to less than 1%, right? And I'm willing to take that risk. Again, it's a different system because of the financial incentive and insurance covers patients, whereas you guys have a different financial system. So that I can see why that would make sense. But our training, the way our system here is a slightly different way of thinking in regards to that. Does that make sense?
It does. It does. Thank you.
Yeah. All right. Dr. Manasawa, do we want to I know we could sit here all day, but do we want to?
I mean, if there's any more questions, I'm happy, we're happy to answer. And what we can continue this conversation. I don't, this is not the end, this is the beginning for our kind of just talking about this, making the work group and, helping with whatever questions and protocols and ways to, because ultimately, Dr. Bagwala, like the philosophy should be that let's get that from 65 to 60 to 55 minutes to 50 minutes to 45 minutes, whatever you guys and girls can figure out, that these are the ways we can create more efficiency in our system so that we save minutes. Then that's the goal for the stroke intervention ultimately.
And this also is not just thrombolysis, it's also the same thing for thrombectomy. Because we cut down the same amount of time for thrombectomy as well.
Perfect.
All right.
I'm really
Well,
happy
thank
that
you
you
so
guys.
much. It was wonderful talking to you all, and I think it was a very good discussion on the acute stroke. And I think we like to carry forward it whenever you're next year in Bombay. I think Dr. Badruddin is expected in next week or sometime, right?
Yeah, so actually, I'm also coming this Friday, and then we're going to be in Surat for our functions for a couple of
Istifada.
for Istifada. We're going to be there, but then I have
Everybody knows about Dr. Rajiv, Dr. Dipesh. They all know Istifada. They all know
so
whatever is coming up in our community. So
I think I have a couple of days on the back end in Bombay. And so let's see with Dr. Badruddin if he has time and we can stop by and at least meet up. Maybe the Friday after the Milad. So yeah, we'll be in touch, and maybe we can figure out nothing formal, just something informal to say hi, meet up, and maybe even just some kind of a chai and talk a little.
It will be great to have you all here, see our facility. Of course, you must have seen Safety Hospital, but in terms of as a protocol of stroke, you can just see the facility, and of course, we can have a healthy discussion about how we can definitely help the patients more.
Yeah. Let's see if we can do something on the October 25th, maybe. So I'll talk to Dr. Badruddin. Dr. Sarwala, are you by any chance?
I won't be going. Not
Okay. I'll talk to Dr. Badruddin, and then we'll be in touch, and maybe we can do something on the 25th or something.
Definitely.
Okay.
Looking forward to it.
All right, great. Thank you, guys. Thank you, everyone, for joining.
Thank you, everyone. Thank you.
Thank you so much. Thank you so much. Have a great evening.
Thank you.
Have a great day, brother.
Good night. Good night.
Bye. Good night.